Thank you very much, Linda, and thank you to the organization for inviting me for this session. My presentation, you have to understand, is really based on a pre-pilot, prenatal, so to speak. So this is what I'm going to talk about, actually basically what we were asked to discuss, the origin of the project, the funding from the Dental Trade Foundation, and current status and what we do doing this, lessons learned and future of the project. So our project actually stemmed from, we did through generous support from DentaQuest Foundation, two very, very important things, and that was to do a survey of Maryland adults to find out what they know and do about preventing tooth decay. It's very limited knowledge and understanding. We also did a series of focus groups across the state of Maryland. One of the focus groups happened to be pregnant teenagers. And we found, I mean, they just stood out. They were so unknowledgeable, disinterested of the subject of their oral health, much less the oral health of their infant. And it was based on that, plus the fact that we know the data in Prince George's County. Prince George's County has one of the highest pregnant teen groups in our state, if not the country. It also has a very high number of low birth weight and preterm birth. So these things really just fit together in my mind, knowing, however, that it may not be easy, and we knew this from this focus group that we had once had, may not be easy to actually get the teens to cooperate. So, but we thought it was worth a chance. And the concept was that we would conduct this pre-pilot project to determine if we could get their interest and their trust, and can we establish any kind of habits. So that's basically what we were setting out to do in the origin. The funding made it possible to try this project at all. And I have to say that we did get from the DTA Foundation about a $4,000 project that was a part of this as well. And the funding has allowed us to purchase numerous items. And we screened hundreds and hundreds of documents because, like Dr. Needleman, we wanted our educational interventions to be evidence-based, not just, you know, what some people think that works, but actually what does work. So it has allowed us to do that. It has allowed us to explore with a number of young pregnant women to actually provide these incentives to schools and to the students themselves. And so the current status and what we do, it's ongoing now. We had to, because it took so long to get through, not the schools, not the school nurses, not the principals, but to get through the school system's research center. It took me 4.5 months to get permission to get through that. And when they give you permission, it's only until the end of the school year. By the time I got permission the first year, it was in April, and they gave me permission until the end of May. That's not a very long time. But we managed to get through that. I got an extension, no-cost extension. And what we're doing now is that we meet every single month in these two schools with these young women. And we have gotten them to really talk very openly with us. They ask us all kinds of questions. Of course, the caveat is the only content we cannot address because it's, you know, a no-no, and that we can't talk about birth control. We can't talk about anything to do with condoms or anything like that, which would probably be the best way to prevent tooth decay among these kids, but that's a different topic. When a student first comes to the session, what we do is to give them a survey, and it's really based on one that we had given to the adults, only, you know, geared down a little bit to find out what they know about preventing tooth decay. Do they know what fluoride is? Do they know what Pitt and Fisher sealants are? And things along this line, and their practices, you know, in terms of when they brush, do they floss? Have they ever had sealants on their teeth? These kinds of things. So that information actually dictated what we started out teaching them, and also set us on the trail for trying to find educational interventions that we could use with them and possibly other groups as well. So this is now the other thing that we always feed them, good, healthy food. And right now, our sessions are only early in the morning, which is good because most of these kids come to school with no breakfast. And we give them many, many educational interventions and things to read. But the most important thing that we have found to do is to get them to teach us how we can teach other pregnant teens how to prevent oral diseases in their own mouth and in their baby's mouths. It wasn't doing any good for us simply going one-on-one. So we do demonstrations on each other. We have videos. We have gotten them involved in focus groups of how to develop, and they've actually helped develop some of the posters that we will eventually publish and distribute, because after all, it's not what we like or what we want, it's what's going to appeal to them. So we ask them to help us. When you're in the dentist's office, what kind of educational messages can we give you that's going to help you keep yourself oral disease free and keep your baby cavity free? We also hold discussions centered on their questions that they ask. And at first, for the first 2 or 3 sessions, they were a little quiet, weren't quite sure they wanted to go along with this gig, but eventually they come there willingly, they really like it, and we have actually a lot of fun doing this. They're very, very back and forth. They're excellent when we do these focus groups because they know they're teaching us. They're tired of listening. They want to tell us what to do. And it works. It really has come out well. And I can tell you of some of them. Well, eventually we'll have the posters done and you will see some of these. But the other things that we have done is we give them every kind of preventive implement you can think of, including, and don't be offended if your toothpaste isn't here, because we bought the least expensive kind in the biggest tube that we could get on sale at that time. We give them toothbrushes, good toothbrushes. We give toothbrushes for the baby. We give washcloths because we want the babies to start wiping, we want the moms to start wiping babies' mouths as soon as they start giving their baby a bath. Don't wait for 2 weeks to 2 months, 6 months, too late. We want the habit starting now, and so this is what we give them, or we tell them what else they can use. We also explain to them when they give their baby apple juice, and if they give their baby an apple juice, 5 ounces of it in a bottle like this, that they're actually giving their baby 4 teaspoons of sugar. They're appalled at this, and so they learn a lot of things hands-on. We also have developed, and these are very, very rough, but brushing charts for them and for their babies, because for cleaning the baby's mouth and brushing their own mouths. Then a book we found that is pretty good with few exceptions, and we would actually use it. This is from the health literacy group on the West Coast, and so we assign different chapters in here that we then discuss at the next time. Not always, but most of the time, because usually we center on what question do you have today. The other thing is we found not only from them, but from our larger survey and from focus groups is that they don't drink tap water. Now this is outrageous because Maryland has about 99% of the central water supplies are optimally fluoridated, and yet it's not being consumed by low-income and Medicaid youngsters and adults. And almost all, except with the exception, I think about 98% of these young girls actually are on Medicaid. So that means that they really fit what our statewide survey did of adults. And so we gave them this bottle with our Maryland logo, of course, the turtle shell. And so the idea of giving them this was because they could fill this up with water, at home and carry it around. And could also use this to mix their baby's formula with to help ensure that the infant also gets fluoridated water. We have given them, because we don't want to just function on one thing, we give them this, which is really set, ready to brush. And we had to alter this slightly because in this book put out by the ADA, it's beautiful and kids love it. But the problem is it's brush, 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 but there's no word, not one word about fluoride in here. So we have taken the liberty of adding the word fluoride to these because it's a concept we want to get across to these youngsters because they can keep their babies caries free if they follow these directions. We also provide them with Lift the Lip. This is from Calgary, and we hope to actually make posters really, really central for use in the U.S. and in Maryland. But it's a wonderful teaching device to be able to use. The one thing that, the other thing that is good, and it's not just because a colleague is in the room, but of course, you know, some of the best information that is in plain language. That's our biggest problem. The most of the educational material either isn't evidence-based or is not in plain language. But this from NIDCR is both. It has good background in it, it mentions fluoride, and it is in plain language to the point where these kids, and they are kids, can read and understand them. This is what we are. We also got into, because I had this feeling when I said, okay, when did you brush your teeth last? And because never want to ask a question with a yes or no answer. We would ask, when did you brush your teeth last? And they would answer honestly. Like some would say, last night. Some would say, this morning. And so we started using disclosing tablets and toothbrushing right there in our little classroom every time. And this has proved very, very beneficial because I doubt seriously if any of these young women had ever felt a really clean mouth before we did this. And we are doing that. Some of the young women also ask, do you have any spare disclosing tablets? So we are giving them, starting this coming Wednesday, disclosing tablets that they can take home and use. We also have shared information for, you know, these are all African American or Spanish speaking young women. And many, many, as you know, in both of these categories also have high rates of diabetes. So we talk to them about their moms. How many of your moms or dads have diabetes? And so we give them information on that as well. And we always try to take into perspective their perspective on whatever X is. And we're in our second year. We're learning a lot from these students. I have to say that this is one of the most challenging projects I have ever done. But it's not because of the students. It's not because of the school nurses. It's not because of the principals. They love us. But it was trying to get through the big hump and getting into there. And we intend to continue this project just on our own because we feel that it's so important and so necessary. So now what we would do, lessons learned, we'd go directly to the school and the school nurse. We now have enough connections with the high school nurses that we can get our way into almost all of these programs. What we really want to do is to get into a school, a high school, where they also have daycare for the infants and the young children, because I feel strongly that this is going to be the place that we can really make the most impact when we can get at both the mom and the baby, and to get others to understand these practices. So there is no funding for this kind of a project at this time, but we will continue it because A, they like it, and it's a good public service, we believe. And that is it. And thank you very, very much. If you have any questions.
I'm really pleased to be part of this forum today and to have the opportunity to hear about all the projects and get to share with you the project that I am on. And again, as Linda said, I'm here instead of Dr. Chung, who's busy getting ready to complete her public health dentistry oral board exams. She would like to be here, but she thinks she's helping us out by getting her board certification taken care of. And many of you who know her will see her at NOHC. First of all, I want to give a big thank you to the DTAF and to all of the funders, and both for funding all of the projects that are so important here, our project included, and also for sponsoring this forum to create access, the importance of creating access to oral health care. And that's obviously a very timely study given the background of the 2011 IOM report, Improving Access to Oral Health Care for Vulnerable and Underserved Populations, and the 2012 report from the U.S. Senate Committee on Health, Education, Labor, and Pensions about the dental crisis in America and the need to expand access. These reports emphasize the serious shortage of trained oral health professionals and the very negative impact that this has on the oral health of the nation. It also emphasizes the need to expand the oral health care provider force to broader healthcare settings and to train non-dental health professionals to provide screening and preventive services. And obviously, we're hearing today a lot about those priorities and how a lot of the care and the services and the education that are being brought through these projects are actually taking place in group settings that are non-dental settings. So the problem is that we wanted to help address was twofold. One is, as others have mentioned today, a huge epidemic in early childhood caries that disproportionately affects young children from underserved communities. And then also during pregnancy, there are many serious oral health problems that can affect mother's health, but also go on to affect infants' health. So the solution, one big solution, would be to provide care that's based on national and professional guidelines for oral care for pregnant women. And those have been issued by the MCH Oral Health Resource Center National Consensus Statement and by the New York State and the California State Guidelines. All of these guidelines emphasize assisting women with getting their insurance because many times insurance is available, but people don't know how to access it properly, can't get through the hoops. And likewise with referrals. In the state of California, now the only time that a person with public dental insurance can get care is when they're pregnant. So sometimes that period slips through too quickly, and by the time we can get all the services up and ready, then women are so uncomfortable in the advanced stage of their pregnancy they don't want to visit a dentist, and then within a couple months after the delivery of the baby, they can't access services anymore. These also emphasize the importance of education on the importance and safety of dental care during pregnancy, of receiving routine care, treatment of tooth decay and periodontal disease, and on the importance of preventive services. And as has been emphasized earlier, that providing this kind of guidance for women during pregnancy can go a long way to help prevent ECC, and that's just such a huge priority right now. So during pregnancy, obviously, mother's health and family in general receive a lot of attention and focus, both in families and in their health care. Unfortunately, relatively few women visit a dentist during pregnancy, so they don't really have the opportunity to receive the anticipatory guidance, the treatment of untreated decay, and things like that that would be important. But the vast majority of women do access prenatal care. So one way to help increase access to oral health care through non-dental settings would be to integrate oral health into prenatal care. And the outcome, we would hope, would be healthy smiles for children and for moms. So the CPOP project, we call it, Oral Health Promotion in Centering Pregnancy, was funded by the NIDCR with support from the DTAF, and the aim and purpose is to improve oral health of pregnant women and babies. This is our full study team, and as you can see, Lisa Chung is a project director on this team, and Lisa originally received the DTAF funding, and she had planned to work with the San Francisco Department of Public Health to develop a small training for prenatal care providers to help them figure out ways that they could integrate oral health in their prenatal visits. And Lisa was working with a team of clinicians from many centering pregnancy healthcare programs, which I'll tell you about in a minute, that worked with the San Francisco Department of Public Health. And the more that we started to talk about the projects, we became really interested in the idea of not just doing a more informal training of meeting and greeting and offering trainings just in lunchtime programs, to the idea of writing a grant and receiving funding to do a pilot study to develop an oral health intervention and to do a pilot of it with a pilot evaluation to see if it would work in a larger study that would become a clinical trial. Our team is multidisciplinary, and another person actually who's here in the audience today I want to acknowledge is Sharon Rising. And Sharon is was the founder of Centering Pregnancy and the founder and the CEO of the Centering Healthcare Institute. And thank you for coming over, Sharon. I also want to just acknowledge that our program officer from the NIDCR that has funded the CPOP study for several years, Dr. Nojak Raymer, is also in the audience with us today. And it's taken this huge team effort between all these different organizations to get this far with giving you some preliminary results on our intervention. And I'm really grateful for the chance to have people come together. So we used a community-based participatory research approach, and we developed and pilot tested our interventions. We're now sort of on the road to figuring out our next steps in terms of getting funding for a clinical trial. Centering Pregnancy, have people heard of the Centering Pregnancy Project? I know I've spoken with a couple people about it today. Okay. So it is group prenatal care, and it's interesting to me because what I'm also hearing today is that most of the programs that people have been talking about offering to children and families are programs that are actually delivered in group settings. And I think it's really a very noticeable and sort of neat and efficient way for people to learn about oral care in groups. Centering Pregnancy is the regular sessioned prenatal care. It's conducted in a group of each session is 2 hours, and there are 10 sessions, and they're facilitated groups led by clinical nurse midwives and MDs. It focuses on health assessment. The women do all of their own belly checks and blood pressures and things like that, and then health education and social support. And there are 200 sites so far in the United States, and it's growing. It's also becoming an actively sought thing internationally. So we worked with CP facilitators, and we developed 2 15-minute interventions that were then integrated into the routine Centering Pregnancy sessions. And they were education and skills focused, brief, interactive, low cost, and sustainable. One thing that we learned when we were doing this project is that we thought we wanted to give the women the Cadillac version of care, and so we thought we'd get these great baby models. They could wipe their mouths in the models, and these big tooth models, and learn all the brushing things, and then we remembered, actually, if we want to take this broadly, it has to be very efficient, and it has to be low cost, and so we set aside those. We came up with some other really great things to do, and the DTAF actually helped quite a bit in making that happen. So we recruited women to participate. Well, first we actually trained 10 facilitators in the program, and those facilitators were at sites that had agreed to participate in the pilot study. And then we recruited women at the 4 different sites, And there are 50 women in our pilot intervention group and 50 women in our pilot control group. And each of the groups had one English language group and one Spanish language groups, and materials were totally developed, and the interventions were delivered in either language that the group was focused on. So for the maternal oral health intervention, we used DTAF-funded toolkits, and our session focused, it was a 15-minute session, focused on discussing and having the women discuss oral health problems they were experiencing during pregnancy, their beliefs about the safety of getting dental care during pregnancy, and the importance of oral health for mothers and for infants. We then had a demo and practice session where the women pulled everything out of their toolkits, and we did, in the group, dry toothbrushing and teaching them instructions for very efficient and thorough toothbrushing. We also had the women learn to do gum self-assessments using the Eastman toothpick test. We gave them brief flossing instructions, and then we gave them these really neat guides that would be part of their notebooks they would take home with them, reminding them of these priorities after the intervention. For the infant session, we also had toolkits, and we had cloths, sort of like this. They were light green. We had toothpaste and toothbrushes, and we also had a BPA-free spoon, baby feeding spoon. And we used all of the supplies as prompts to deliver the intervention. So we emphasized infant oral health and the importance of a dental visit by age 1, healthy feeding practices, avoid sharing saliva, and the spoon is very handy, and emphasizing that, and infant oral hygiene, and then we had these guides that were also in English and Spanish, and the moms really liked that saliva has germs poster there. It was a lot of fun. And again, these were to take home as reminders for what would go on after the babies were born. So all of the women in the intervention and the control sites received dental exams pre and post and completed questionnaires about their oral health. And we wanted to do a pilot evaluation of how the groups compared on their oral health outcomes, and that's what I'm going to show you this afternoon. So for preliminary results of the dental exams, we had a plaque assessment, bleeding unprobing assessment, and periodontal probing depths. The first graph shows you the women's, by group, the extent to which the women in the group either had a reduction in their plaque levels, or an increase in their plaque levels, or no change in their plaque levels. So the intervention women are in the darker blue color, and the control women are in the lighter blue color. So over 75% of the women in the intervention group had a decreased plaque level in their assessment after the intervention. The timing of the dental exams was about 10 to 12 weeks apart from the pre to the post. And we were totally surprised by this, that the women in the control group actually developed more burden on their oral health status across that 12-week period. So this shows you that over 50% of the women in the control groups experience greater burden in their plaque levels. And I guess in a way it's not surprising. As pregnancy goes on, it gets more difficult to take care of all of the daily things that need to happen. And this was something that was sort of unanticipated. In terms of change in number of bleeding sites in the group, a very similar pattern. Close to 80% of the women experienced in the intervention group a decrease in their bleeding sites, where more than 50% of the women in the control group had an increase in their bleeding sites. And then we see the same pattern with the mean probing depth that was conducted. So again, the women in the intervention group were really able to do something to change their oral health status, and the women in the control group, their oral health status factors on these things became more burdened. So we're really encouraged by these pilot results, and we think that we have some good ideas and things to move forward with a larger study. Again, further funding has come from the NIDCR to follow up the moms and the babies at 6 months of age and at 12 months of age, and these are grants that were awarded to Dr. Chung through the UCSF NIDCR Disparity Center called the Can-Do Center. And we're looking at bacteria levels in the babies and the moms at 6 months and at 12 months to get some kind of sense of if we're on the right track here, if the infant oral health intervention that we gave shows some effects post. So right now, we're working on getting our results published and looking for funding to get the CPOP intervention into a clinical trial. And we're also interested in exploring how we can adapt the intervention to integrate it into other settings. So CPOP is a very innovative model with promising results. It creates access to oral health care in a non-dental setting, and it trains non-dental professionals to deliver oral health care. And we would have a really broad impact if a clinical trial showed results and we were able to roll it out nationally in centering pregnancy. So again, I want to acknowledge our funders for helping and supporting us very much in this thing. And thank you so much, everyone here.